Welcome to the Practice and Policy Academy Plenary 3. My name is Lexi Allison, and I'm the Lead Administrative Coordinator for the National Center on Substance Abuse and Child Welfare. Thank you so much for joining today's webinar. Before we begin, we'd like to cover a few housekeeping items. Today's presentation will be recorded. We will disseminate the recording and slides to attendees and project liaisons. Once you receive the recording, please share with your Practice and Policy Academy team members who are unable to join today. Please use the chat function in Zoom to participate in the conversation. The chat function allows you to send direct messages to the panelists or to the group. If you're experiencing technical difficulties, please send the panelists a message via the chat box and we'll reach out to assist you. When you have a moment, please share your name and location in the chat box so we can see who's participating today. Also, there will be time at the end for Q&A. So please use the chat box to submit your questions. We'll do our best to get through all of the questions during the live broadcast. If we're unable to get to your question, we will follow up with you individually after the webinar. Now I'll pass it to Ken DiCercio.
Good afternoon. Some of you, good morning. Nice to be with you again. My name's Ken DiCercio. I'm Program Director of our in-depth technical assistance program under the National Center on Substance Abuse and Child Welfare. I know we've covered this slide on our previous two webinars, but a reminder, the National Center is a program of the Substance Abuse and Mental Health Services Administration, SAMHSA, Center for Substance Abuse Treatment, and the Administration for Children, Youth, and Families, the Children's Bureau. They have been the funders and the supporters of the National Center since its inception around 2002. And we've appreciated their leadership, their guidance, and their support of our efforts to help you and many of your colleagues around the country to support better serve families affected by substance use disorders, either in or at risk of entering the child welfare system. Recall this is our third webinar with our subject matter experts for the Practice and Policy Academy. Dr. Turpin presented our first webinar on treating pregnant women. And then Dr. Grossman earlier this month around treating infants affected by prenatal substance exposure was very much a parent and family-centered approach, kind of de-emphasizing the medical approach, if you will, and treating infants like infants and parents not like patients, but as parents. And today, Dr. Jones is going to talk about family-centered treatment and all the components that go along with family-centered substance use disorder treatment. I mean, historically, I grew up professionally in the substance use disorder treatment system, and historically, right, our services focused primarily on parents. There are a couple exceptions to that. Pregnant and parenting women programs supported by CSAT in the late 80s, where primarily a mom with a young infant or children under 5 or 6 years old could come into substance use disorder treatment. We still see those programs around, but typically the focus of the treatment system was focusing on the primary clients with the disorder, right? And in the child welfare, historically, services were very much geared toward children being affected by child maltreatment and certainly by removals and the trauma associated with that. And rarely did those systems come together in terms of treating the whole family. Rarely were they coordinated, let alone being integrated in terms of an integrated family-centered treatment approach that addresses and deals with both challenges and supports needed for parents, as well as the interventions needed for children, both developmentally, increasing parenting capacity, strengthening parent-child dyads, et cetera. We even see it in the performance measures under GIPRA, under the Center for Substance Abuse Treatment, going beyond just traditional substance use disorder treatment, measures importance of things like social connectedness, employment, education, mental health, as well as physical health care. And a lot of work's been done to integrate primary health care with mental health and substance use disorder treatment. And the reason you're here as part of the Policy Academy is to address infants with prenatal substance exposure and the implementation of CAPTA that part of CAPTA that addresses infants. And even that legislation, as well as the Family First Prevention and Services Act, recognizes the need to address the total family, right? So in CAPTA, developing plans of safe care, not only for the affected infant, but the affected family or caregiver. And the legislation speaks to that, and with an expectation that plans of safe care will address both the substance use disorder treatment needs of the family, as well as the health needs of the infant and family as well. Then if we fast forward a couple of years later to Family First Prevention and Services Act, FFPSA allows for foster care maintenance payments to bring children into substance use disorder treatment with their parents as an alternative for removals for those children that are actually placed in foster care, but either quickly reuniting them with a parent in substance use disorder treatment, or as an alternative for actually placing a child or an infant in a foster home or a different placement. So FFPSA allows for those maintenance payments to be used. Hopefully that is part of your participation in the Policy Academy. You'll be taking a look at that opportunity that's been available since October of 2018. We're aware that there are very few states that have moved forward with trying to implement that provision of Family First, of FFPSA. During today's webinar, Dr. Jones will describe how family-centered treatment for this population incorporates the mother's and father's need for clinical treatment for substance use and mental health disorders, appropriate care for the infant who may be experiencing neurodevelopmental challenges and delays as well, or the physical effects of withdrawal symptoms from prenatal substance exposure, and clinical and community services and support that strengthen the parent's capacity to nurture and care for the infant and to ensure for safety and well-being. A lot of conversations, right, around plans of safe care and how that's not just a child welfare responsibility, but a community responsibility, and not one agency can do it alone. The kinds of services and supports that families need and the complexity that families bring to us requires an approach that integrates, incorporates, or provide access to many services, family-centered supports and services that support recovery, that support keeping families together, that support reunification. It's my honor to introduce Dr. Hendrée Jones, who's a professor with the Department of Obstetrics and Gynecology at the University of North Carolina, Chapel Hill, who's a director at UNC of the Horizons Substance Use Disorder Treatment Program, which is a program for pregnant women and or parenting women and their children, including those whose lives have been touched by abuse and violence. In addition to her work at UNC, Dr. Jones is an internationally recognized expert in the development and examination of both behavioral and pharmacologic treatments for pregnant women and their children in risky life situations. She's received continuous funding from the National Institutes of Health since 1994 and has written more than 195 publications. Dr. Jones has authored 2 books, one on treating patients for substance use disorders and the other on comprehensive care for women who are pregnant and have substance use disorders. You may be familiar with the mother study. Dr. Jones was the principal author of the Maternal Opioid Treatment Human Experimental Research Project, but we have always referred to it as the mother study. And that study was to investigate the safety and efficacy of maternal and prenatal exposure to methadone and buprenorphine. Dr. Jones has received many awards, probably more than I'm going to mention here, but I'll mention a few. She won the Betty Ford Award, was awarded the Betty Ford Award from the Association for Multidisciplinary Education and Research in Substance Use and Addiction for her scientific contributions in advancing women's addiction treatment. In 2018, she won the National Association of State Alcohol and Drug Abuse Directors, or NASADAD, their Women's Services Champion Award. And in 2019, she won the Marion W. Fishman Lectureship Award, which recognizes contributions of outstanding women scientists in drug abuse research. I could go on, there's a few more, but I'm gonna skip those. Dr. Jones is also a consultant for the United Nations and the World Health Organization, and and really has international experience and an international view of the importance of a family-centered approach to substance use disorder treatment. So with that, I'm going to turn it over to Dr. Jones. Andre?
Thank you so much, Ken, and thank you everyone for being here. Good morning, good afternoon, because I know we're spanning some time zones, and I want to thank the National Center on Substance Abuse and Child Welfare for this wonderful opportunity to have this conversation. And I want to make sure that we leave enough time for Q&A, because I think that's the richest and best part of any presentation. And I also want to thank the people that sent in questions ahead of time. There were a couple of them that I'm going to do my best to touch on during the time we have together. One of them was how can the court system help with supporting families that are affected by substance use disorders, as well as another question was how does Horizons partner with governmental agencies? And then a third one in terms of what challenges does Horizons face when providing family-centered care? And let me start with that one. We face challenges every day, and we learn as we go. So I hope some of the mistakes that we've made, lessons learned, can be really helpful, as much as some of the successes that I will share with you today too. Let's see. I am moving my cursor and hopefully can move my slides. Yep. Nope. Oh, there we go. So let me start with history, because I think when we think about any topic, and thank you, Ken, for doing a really great summary of how we got to family-centered care. In sort of the look back that I was doing, I really like to think about the early 1900s. And when treatment for substance use disorders and recovery was first recognized, even in the 1930s, they did recognize that it was a family disease. The abstract you have here around anabuse was one of the very first ones that I could find that actually specifically mentioned family. And it noted that patients were failing treatment if they didn't have that family support. And I use that in quotes because I don't think that patients fail treatment. I think that treatment fails the patient. In the late 80s, early 90s, there were a number of projects funded by SAMHSA and the National Institute on Drug Abuse called the Perinatal 20. And they were demonstration projects focused on how to help mothers and children that have been prenatally exposed to cocaine and other substances. And there were definite aspects of family-centered care in that, everything from having daycares on site to moms and children living together in residential settings. And then we've learned a lot since that time. So continuing in terms of our history, in the 1970s, one of the very first models we had was the family center model. It was established by Loretta Finnegan, and it was at a time when the opioids were much more prevalent, before the cocaine epidemic, but a time of the opioids. And she was really one of the first providers that wrote about a comprehensive care approach to pregnant women that had opioid and other substance use disorders, but focused on opiates. And methadone was the medication that we had to treat opioid use disorder for non-pregnant patients as well as pregnant patients. And you can see there in that diagram, she really put together the addiction treatment with psychiatric services for co-occurring disorders, as well as the obstetrical services. And that really was kind of the first model that got published and disseminated. People started talking about it. And it was in the 1980s, and I think that Beth Reed is one of the unsung heroes of our field, because she was really the one that started to write more about the psychosocial characteristics of women and parenting women who had substance use disorders, and to highlight the violence and victimization and trauma that many of them had experienced, not only during childhood, but also into their adult lives, and how that can really color how women perceive substance use disorder treatment and the services that they receive, as well as providers, and vice versa. And then, of course, in 1992, the very first tip we had on women was tip 2. There was a lot of things that were put out in that tip that we still do, or that we know are some best practices, the language and other things, and it certainly has evolved, but there's a lot of really good aspects of that that are still carried on today. And then to finally, just to highlight on this slide, there's a wonderful document that was published by one of the ATTCs that gives a really rich history of family-centered care. And so that's there, and I encourage you to check it out. So when we talk about family-centered care, one of the first things we have to talk about after we talk about history is how is family defined? And for the women that I have the honor and pleasure of working with, we think that's really important to let them define who their family is. And a lot of times it's not that traditional family unit that maybe we've been indoctrinated to think about. But there are many women that come in as single parents, but have a very rich self-identified family. So family can be blood relatives, it can be grandparents, it can be foster care relationships, traditional families, adoptive families, step families, extended families, and then there's people that we self-select, that we start to call aunts and uncles and selected family. So the easiest kind of way that we've conceptualized family is whoever are her closest emotional connections is how we define family. And so when we talk about family-centered care, it's really important to remember that treatment needs to best support families. And so that's not just the woman, that's not just the child or a partner, it's the whole family. And when we're best supporting each of the individuals, then we can also collectively look at the whole about how to support them. And I know Matt Grossman gave a talk recently to this audience. And so I'm sure there was a lot of talk that he talked about in terms of keeping moms and babies together. And so we know that particularly for opioid use disorder, and NAS treatment is a very effective way to help reduce the signs and symptoms of neonatal abstinence syndrome and promote healthy long-term outcomes. In terms of what are some key concepts when we think about family-centered care, one of the most important ones for me is that substance use disorders are treatable. And that means that there's hope. That means that there's a set of evidence-based tools that we can provide that, like in many other chronic illnesses, oftentimes those tools aren't able to help every single person. But when you look at the overall continuum, there's a large proportion of people that can be helped. The parent gets to define family, as we talked about just a minute ago. And we know that families are really complex and they're dynamic, and people enter and exit families in terms of in relationships, in terms of quantity, frequency, and healthy relationships and the way they interact with each other. And so we have to be cognizant and be able to respond as treatment in a dynamic way to those dynamic changing aspects of relationships. And another tenet that we use is that when conflicts happen, and conflicts happen in all relationships in different ways, making sure that safety is first for the child and for all other members of the family. And how can we get through, how can we understand that conflict and move through to the other side in healthy ways? Oh, there we go. So in terms of what needs families have, again, thinking about the family as a complex unit, we know that parents come in with their own set of needs. And so we have parenting skills. A lot of times the women that I work with have not had parenting models that have been healthy in any way, shape, or form. And so helping them understand what healthy parenting, what nurturing parenting, what attachment-based parenting looks like can be really helpful for them, because that's not something that they grew up with. Understanding about their family connections and where they want to strengthen family connections and really work on them to make them healthier, where they need mental health from an adult standpoint. Is there medication that is also needed? So can you get mom and her partner, maybe it's a dad, into treatment together or separately? Because we know that when the two people in that couple, to give an example, are in treatment, that their outcomes are much better. We know that domestic violence or other types of interpersonal trauma can certainly be at play in families that are affected by substance use disorders. And so how do we maintain that safety plan, the healthy living and safe living arrangements, and still allow perhaps contact with the children, maybe with the courts or other types of appropriate supervision? The family itself also has some really basic necessity needs, at least the families that I work with, in terms of transportation challenges, food challenges, just like food security, maybe water security is also something that's important. Family counseling versus family education, where do you kind of draw that line? Employment, so we know that when families are able to have that economic self-sufficiency, that can promote healthy long-term outcomes. And then certainly the child or children, where we want to make sure that they are growing up with healthy well-being. We're looking at their behavior and seeing how we can help the parents or the caregivers in that child's life have the tools that they need to help promote healthy cognition, development, and behavior. And certainly their mental health. And then as children get older, or there are older children, that adolescent substance use problems, can we prevent those or get on top of them really quickly and prevent other risk behaviors? When we think about family-centered treatment, we know that it happens on a continuum. It's not a yes or a no, that there's this really rich continuum that happens all across the country in different treatment programs. And so we have this most basic, where it doesn't talk about the family at all, it only works with that one individual, to maybe there's some services with some family involvement, maybe there's a little bit of education for other family members, but really the whole focus of treatment is on that one individual parent. In later stages, there'll be children that accompany the parent or parents to treatment, but really they don't have a treatment plan. There's nothing more than they're like residing with that parent, typically a mom. In the stage that's sort of phase 3, there are parents and children services. So now the child might have a treatment plan and is getting their own services, as well as the parent having its own individual treatment plan. Then there are more coordinated family services. And then finally, sort of the holy grail, the best is that family-centered treatment model, where every family member that needs it has a treatment plan, a personalized care plan. And those are looking across, we're looking sort of across and individually to see how they are coordinated, where synergies can be found for care, because we know when we have a healthy mom and a healthy dad or other partner, we're gonna be more likely to have healthy children. When children are struggling, moms and dads or other partners might also be struggling. So what can we learn from all of the different modalities to help strengthen that family? So those treatment plans need to include family issues and certainly best parenting practices, understanding the needs that each individual family member is bringing, and then how that informs the collective set of needs. One of the things that we really work on in Horizons around parenting knowledge, as well as parenting practices, is not just telling women what to do, but really showing them how to do, breaking it down each step so that they feel very comfortable and confident that they can then go out and practice those skills rather than just being told what to do. Even when you think about all of the environments, no matter where you are in your service delivery, a basic place to start is how child-friendly are the offices or practices where you are. So do you have toys? Do you have things for children to do? Do you have, what are your hours like? Do you have places for naps, perhaps, for younger children to be able to do that if a parent or mom or caregiver needs to be coming in? And then also thinking about our outcomes, are they just really focused on the parent? Are they just focused on the child? It's best when we can have outcomes focused on parent, child, and that dyadic relationship, that space in between, for example, mother and child. And I can't talk about family-centered care or substance use disorders without talking about trauma. And this is the definition from SAMHSA that I'm quite sure you all are familiar with, which, back a long time ago, it used to be thought of as trauma was an event, but it's certainly, we know now, it's not an event. It is the way that that event or set of experiences is experienced by that person, and then the effects that event and the experience has on the person's well-being going forward. And so it's the event plus the experience plus the effect that makes something a trauma. And when we work with both mothers and children, which is what I usually work with, there are different forms of trauma that I think it's important to keep in our minds. Not that these are exclusive categories. Certainly women and children and parents can have overlapping, but there's an acute trauma, which is that one-time single event. There's that chronic trauma, which is most often what the women that I work with have, as well as many of the children, the interpersonal violence exposure that sometimes happens in childhood and or continues into adulthood. And then there's the complex trauma, which is that 0 to 5, very vulnerable or early moldable years. And it is often inflicted by adults who are responsible for caregiving for those children. So when we're working with family-centered care, we want to have a trauma-responsive approach. And so really understanding how prevalent trauma is in the patient population or care population that you're working with is important. One of the things we do is use universal precautions because we have such a high prevalence of over 80% of childhood and or adulthood, physical, sexual, and emotional abuse, we treat everybody as if they have had trauma. And so we want to recognize how that trauma has influenced them, what's happened to them that might help them perceive what's happening in their world. There's lenses that they've learned throughout the years to put on to really cope effectively or the best that they can with the experiences that they're having. And then understanding that, then we can put that knowledge into place. So rather than looking at blaming behaviors, why did she do this, or what's wrong with her, it's really, wow, let me understand what's happened to her and how can we best respond to the behavior that she's showing us. What does that mean we need to do? Other concepts that are really important in this trauma-informed approach is to establish safety. And that means physical safety, so making sure that she feels she and her children are going to feel safe and secure in the space, and also emotional safety. So one of the things we do at Horizons is we have our rooms and our therapy offices have not the overhead fluorescent lights, but we have floor lights that are soft and warmer. We have some blankets, we have some pillows, we have squishy things, we have little squishy things that you can manipulate. Oops, there goes my light. So that it can help people deal with triggers or really uncomfortable emotions. We're trustworthy and transparent to the best of our ability. So telling people what's going to happen before it happens, being really clear about what our expectations are and what their expectations are for us as we enter into this care relationship. Peer support is a huge element of what we do at Horizons. We have many graduates of our program that then come back, that are hired back if they have at least 2 years of sustained substance use disorder remission. And they are wonderful role models for our families. And they can help with child protective services or going to court and things like that. The mutual collaboration and mutuality is that we try our best not to have so much of a hierarchy, but it's very much about you are in control of the situation in your treatment. So what can we do to help best meet your needs and help best meet your goals, help you meet your goals? Empowerment, voice, and choice is also incredibly important, helping women find their voice and use their voice and advocate for their own needs in the most appropriately assertive ways possible. And then certainly this is something that Horizons continues to evolve in, is understanding the cultural, historical, and gender issues about what helps people feel safe. So other things that we work really hard to do is understand treatment from that person's viewpoint to provide integrated services. So it's not just parallel. So you're going from prenatal care to meet with your therapist, to meet with your case manager, to meet with the parenting coordinator, and nobody talks to each other. It's very much working in a coordinated team so that everybody with appropriate releases of information knows what's going on. And that can help make the system more efficient in care and also promote a much healthier and more positive experience for the women and the children that are being worked with. Thinking, we always keep in the back of our head, like, how might trauma be influencing the situation or interaction that we're having? A lot of times the women that I work with are perceived as being really judgmental and harsh and angry. And the way I like to conceptualize that is that's fear. It's the armor that they've put on to successfully get through life to this point. So what do we need to do to earn their trust to help them take that armor off? And then also for the family members, maybe who don't have active addiction, but have been, allies with the women or the other parent that is struggling, helping to give them hope, helping to give them education, and helping them to see what they can do to really make things better. So here are some wonderful tools in terms of trauma-specific interventions. So I've talked now about sort of that trauma-informed or trauma-responsive environment. There are also very specific trauma evidence-based tools that can be used, and these are different places where you can find them. There's some really great links. In terms of individual therapies or group or therapies that can be, or interventions that can be used in group format, dialectical behavioral therapy, I have to say, by Marsha Linehan, is bar none the women that I work with, it's their favorite part of their treatment experience, giving them really practical skills and tools for rolling with resistance, for increasing their mindfulness, for understanding how to roll with discomforting emotions and lean into that discomfort. Seeking Safety is another one by Lisa Najavitz that has a tremendous amount of empirical evidence behind it for men, for women, as well as veterans too. So there's just a laundry list for you if you're interested in learning more. And as we talk about doing this family-centered work, and given the high prevalence of trauma that occurs in our population that we work with, it's incredibly important to also make sure that we're addressing vicarious trauma, because you as caregivers working in a court system or working in a child protective service system or working on any of the front lines are at risk for just listening to stories and witnessing things that are really traumatic. Then you too need to figure out how best to make sure that you are okay and that you are healthy and have good well-being to be able to best support the families and the children that need your help. And so we think about how we help do that in really practical ways. And so we do that through supervision, we do that through peer supervision, we do that through, I do a thought for the day every day that I send to all of my team at Horizons, just to give them hope, to give them help, to give them a place, a safe space to talk. We have a treatment team that happens every week, or just some of those examples. We also developed a self-care toolbox. It's about 150 pages now of all these wonderful self-care tool tips, including developing a self-care emergency plan so that when you do get really stressed out, you have something immediately you can turn to. We work on giving all of our team grounding skills so that when they do witness or hear something that's really traumatic, they can stay very grounded themselves and then help pass on those tools to the women and then age appropriately the children. We also practice mindfulness and self-compassion. Super easy as a provider or a caregiver in working in our system to be really hard on yourself. And we can always easily look at the failures, and it's much harder to sort of see those successes. So pointing those successes out for people and helping people remind themselves to be kind to themselves is also important. When we think about acknowledging the positive, looking for that post-traumatic growth, there's some really powerful, amazing things that can come out of really adverse experiences. And then also to just looking for resilience and recognizing and calling that out and honoring it. In terms of best practices for parenting skills and education, so much of it is really based on the social learning theory. So one of the things that we do is help teach parents how to do things, what are those things that they can do to improve safety in their home, just like even as a small example, physical safety. So like plugging those outlets, making sure that cords aren't around, thinking about the window dressings that you might have, or, and then also understanding how to be empathetic and respond, identify children's needs and respond to them in a mirroring way, are examples of things that we do. So other things in terms of having healthy, secure relationships with caregivers, we know that that has a really positive impact on child development, as well as, you know, kind of the opposite, that insecure, disorganized attachment can lead to, or is associated with, poor developmental outcomes long-term. And so we know the importance of those patterns that are learned so early on in childhood. And talking to the women that I've had the honor of working with, you hear so many of those patterns where they really did have insecure, disorganized attachment growing up. And so then now helping them to switch that model and learn new tools is not easy, but when it happens, it's incredibly well worth it. I can't tell you how many women that have come in that talked about all they knew how to do was beat their children. That was what they thought discipline was, and understanding the difference between punishment and discipline has been really eye-opening, and giving them new tools like timeout, or taking a deep breath and counting to 10, things like that can be so helpful. Other things around parenting skills and education, we want to make sure, obviously, no matter what intervention you use, aiming to improve that attachment, that healthy, nurturing attachment relationship between children and caregivers. Increasing sensitivity. We know that caregiver insensitivity is a risk for child maltreatment. So understanding how we can sort of see beyond the end of our nose and help mirror and understand children better and what they're trying to tell us. And then certainly using evidence-based practices. 3 of the evidence-based practices that we love at Horizons and that we use every day include the circle of security, child-parent psychotherapy, and the attachment biobehavioral catch-up. And I'll talk about each one of those briefly. So we know with circle of security, that has been used all over the world. It's been translated into so many different languages. It's really focused on children under the age of 6, which is a lot of what Horizons has, that sort of 0 to 5 age. It's something that's very prominent for us. There's a parent education part, there's this DVD, there are different levels of training that you can get, and it's been really helpful to understand sort of exits and entrances and help parents understand how they were parented and then how that influences the choices and what they're doing with their children, and help them to teach them different skills. In terms of parent-child psychotherapy, again, this is like another one for younger children. To qualify for that, you need to be a child that has had a traumatic experience. And really the whole idea is to sort of support and strengthen the relationship between the child and caregiver as a vehicle. That relationship strengthening is really a vehicle for helping the child's emotional, cognitive, and social functioning. When we talk about the biobehavioral catch-up, so this is for children that are much younger. It's very much looking at kind of having the child lead, following that child's lead. What are the nurturing behaviors that need to happen? How do you learn to have fun with your child? What are those things that you can learn to delight in with your children? And sometimes that is so incredibly hard for our women when they've been drug abstinent for a short period of time and their brain is still adjusting and trying to make dopamine, and so nothing feels good to them. And a lot of times there's so much guilt, shame, and stigma around not feeling joy or not feeling delight in what their children are doing when they know cognitively they should be, but they just can't bring themselves to because their brain needs time to heal. So working in that in practice takes a lot of effort and time, but well worth it. These are other interventions. For sake of time, I won't dwell on that, but there's some other evidence-based practices that you might recognize here for a variety of different ages and stages, all the way up to 16 years of age. So when we look across all of these different parenting programs, skills building and education programs, there's a number of common elements with them. And I think the important thing is to not think that any one intervention will work with all families. We need to be cognizant of cultural and other diversity areas in terms of language and ways families are put together and fit together and communicate. So being sensitive and responsive to that, and some of the previous interventions that I showed you have taken a really hard look at that and are good for different types of cultural diversity and racial diversity too. So understanding how, what the needs are, understanding what kind of staffing you need, how much training you need to do these, can you offer them individualized, really making efforts to engage fathers is another important element. Treating parents as equals and not this hierarchy of top down and we know what's right for them, because really they're in charge and ultimately they have control. Being able to tailor those programs to the specific family that you have in front of you, being able to address trauma are all really important. Thinking about the family-centered treatment and the need to not only have that parenting piece, but also you have to heal the parent themselves or help them heal themselves, then a lot of that can be done through individual counseling. And so there's a number of evidence-based behavioral therapies that you'll see on this slide. Horizons, as I know I'm supposed to use as a model, uses a lot of these. Anything from contingency management. We have a small donation room, and so when women get a full dose of treatment, their behavioral treatment, they get their 4 hours of group in. Each day they can go to our incentive closet and immediately get a reward for their positive behavioral emission of attending group is one small example of that. The cognitive behavioral therapy, again, an example of that is the dialectical behavioral therapy that has worked really well for our women. Family counseling, I cannot say enough good things about Lisa Saldana's work. And this has also been work that's been done with all families that are Child Protective Service involvement, as well as family drug court. There's some, while these are still kind of early, newer demonstration type projects that need greater verification, what she's seeing is in terms of positive engagement, being able to discontinue substance use and improve parenting and other positive outcomes, Child Protective Service outcomes, has been really impressive. And so I would encourage you to check those out. So one of the things that was asked in the beginning is what courts can do to help. So to answer that, it's looking for evidence-based practices that can be used in the courtroom, that can be used outside of the courtroom. You as the treatment court looking for treatment providers that use evidence-based practices that you can partner with, because not all treatment is the same, not all treatment is good. Another thing that is really specific that you can do is think about the language that you use. So here's a beautiful slide about stigmatizing language and then preferred language options. And I'll mention two. One is the use of addict as a noun, unless we were in an NA or an AA room where it is very culturally appropriate to use the word addict as a noun and call yourself an addict. Outside of that, if we're professionals treating or helping in helping professions as a professional role, we need to then therefore understand that we have to use language that honors substance use disorders and those individuals that have them as medicalized illnesses for which there are treatments. And so talking about person first language, so it's a person with a substance use disorder, is a really important and empowering message for people. Also talking about urines, the only dirty urine I've ever seen in my whole life is urine that has dirt in it. We would never think of calling an HIV positive test being dirty for HIV. So why do we call urine tests dirty or clean? So using language that is medicalized, that honors that test as a biological indicator of recent substance use is important. So positive or negative. What are some of those practical considerations for family-centered care? It's hard. So there are transportation issues that need to be thought through. Can we even get the whole family there in one van or in one car? How are they going to take the bus? What are those levels of concrete expectations and explanations? And what language do we need to use to best meet the needs and comprehension for the different family members? If we have a whole variety of generations that we might be working with at one time, what language do we need to use and how are we flexible with that? Collaboration with Child Protective Services is super important. We have a really great relationship with a lot of our Child Protective Service workers in the county that we're in, which is Orange County and Wake County, to call out to making sure that we have really good releases of information so that we're not inadvertently having a breach of confidentiality that's going to come back and really harm the woman, the children, or the programs or providers that we're working with. How do we even get the whole family into treatment? Because there are so few truly family-centered practices in the United States. So it's a lot of coordination and calling around and figuring where can one partner go and another partner and what happens to the children and where can they go. Thinking about financial debt, criminal records, and safe housing. For a lot of the families we work with, these are the most pressing needs that are keeping them from getting well. If you have a criminal record, you can't get a job, you can't even apply for an apartment, even if you can afford it. And so that those structural issues end up pushing people back into the only thing they know how to do, which is in terms of that drug using context. And I guess the last thing on this slide is never underestimate the power of stigma and discrimination, because unfortunately it is alive and well, and we need to stand up and call it out every chance we get and help people heal from it. Practical considerations too for us is how to have shared decision making, especially when you have multiple family members. So how do we make that work in an honoring and respectful way? Being really concrete in our language and specific actions. Sometimes what happens with the family meetings that we have when we have parents there, we have Child Protective Services there, for example, and we might have our therapist there. There's a lot of almost interpretation that our therapist ends up doing so that we can help explain what the woman might be saying, trying to say, or the parent might be trying to say to Child Protective Services, and then helping Child Protective Services sort of structuralize, make things more concrete and very specific steps so that the women know exactly what they need to do to be able to meet their expectations, to be able to have positive Child Protective Service outcomes. Being really cultural responsive is also another huge challenge that we have. The confidentiality, of course, when we're dealing with multiple family members and multiple systems is also a challenge. This was a really nice paper that was published not too long ago that talked about, from the women's standpoint, what are those barriers? So a lot of times we'll hear, well, women don't want to come to treatment, or they're scared to come to treatment, and they're not, or we have a hard time retaining them in treatment. And then what are the barriers for ongoing recovery? And this was just a nice graph that I found, or a nice chart that I found that really kind of lays that out. And certainly Child Protective Services, I've heard women talk about, and actually just on Tuesday in a group that I led, one of the women talked about being really, really scared of coming into treatment because of Child Protective Services. And with her Child Protective Service workers' help, she actually realized it was one of the best things that ever happened to her, because she could be honest and utilize the supports and resources that the Child Protective Service agent was able to provide her. And she really appreciates that and has great gratitude. Wait time, so being really sensitive around treatment on demand. A lot of times women will say that they're ready and then something happens really quickly. So if we can kind of capture that window of opportunity where they are ready to make those positive changes is really important. Making sure that counselors or whoever it is that are working with the women and the children, that they have the tools they need to be able to effectively engage and speak the women's language, understand their viewpoint, and be able to respond with empathy and compassion. Childcare is also often a huge barrier for women getting into treatment because there are very few places around the country that actually allow women and children to be together in that residential setting. Or how do you get childcare if you're attending an outpatient setting? And so for the court system being mindful of that too, helping women be able to find that childcare and that safe childcare. And then certainly, of course, safety and then stigma and discrimination can occur in all parts of our system. The other thing that this paper did a nice job of is just talking about what are those facilitators for women getting into treatment, staying in treatment, and treatment engagement, and that is Child Protective Services. So I mentioned it can be a barrier, but it can also be such a facilitator and supporter of treatment. And then most importantly, hope. The thing that I'll say, one of the unifying themes that I found throughout the years that I've worked in this field is that women need to have hope, and providers that care for them have to sometimes hold that hope. And when you can envision a better future, you're much more likely to be able to get to it. So I've talked a little bit about horizons. This is what our model looks like. We have a unified treatment philosophy that is informed by social learning theory, by relationship and empowerment theories. We provide substance use disorder treatment in terms of residential treatment, outpatient treatment, individual therapy, as well as counseling too. We do that in a trauma responsive way. We have a 5-star licensed daycare or informal daycare for our outpatient program. We have transportation that's provided to and from. We also are very lucky to have a free bus system so that women from the radius and Chapel Hill can come to us. One of the most important things I think we do is actually that case management piece, helping getting women hooked up and their children hooked up with a pediatrician, with dental care, with primary health care, with OBGYN care. We do offer that on site. Food, housing, helping them figure out what educational goals that they have is important. Helping with overcoming legal aid. We have that parenting early education piece, which I already talked about, psychiatry on site, OBGYN on site. And we also provide medication-assisted treatment for those women that have an opioid use disorder and want it. And this is who we serve. Amazingly beautiful women. To give a short example of our residential treatment, so this is a mom, she's 32 years old. She's been using heroin intravenously. She's also using oral benzodiazepines. She has 2 children, a newborn and a 3-year-old. She's coming into treatment and she's coming directly from prison. So we're gonna screen and assess her over the phone. The prison will bring her to our residence, and Child Protective Services says, we trust you, Horizons, to care for this mother and the children. And so she's going to start attending groups. The father is involved in this case, and so he's going to bring that 3-year-old 1 month later. We have a set of assessments, and based on those assessments, we're going to provide those specific parenting interventions. And then we have a continuing care part where she can continue that parenting piece, continue that case management and individual and maybe even couples counseling. An outpatient example. It's a mom who's 25 years old. She's got prescription opioid use and smokes cannabis. She's pregnant with her first child, unemployed, and living with her mother and stepfather. So again, we're going to screen her over the phone. We're going to be able to immediately take her in because there's no wait list or waiting pool that we have for outpatient. Based on the assessment, she might get some circle of security, some just general parenting groups. She's going to tour labor and delivery and the newborn postpartum units. We'll go ahead and work with her to develop what elements of that plan of safe care need to be developed and what she needs to best meet her needs and meet the needs of her child. And then again, that outpatient continuation would happen. I know Matt Grossman already talked about this, so this is just a reminder that Eat, Sleep, and Console is very much a family-centered element of a family-centered model. In terms of a little bit more about what we do, we have therapeutic services for the children. So the vast majority of them get screened and assessed, and then services on site as they need it. So this is just an example of our postnatal protocol. We very much focus on strengths and learning infants' cues or older children's cues. This is an example of postnatal. So we're going to have folks actually going into the hospital and then meeting with her. One of the things I was thinking about as I was putting this talk together is what can we learn from prevention? There's some really wonderful family models in prevention, and thinking about how we can be creative and really apply those family-centered prevention models to treatment. And to the best of my knowledge, there's not a lot of work that's been done on that. So it's just something I wanted to raise as you all think about how you are creating your systems of care. In terms of shared decision-making, this is just one more slide about that, so just a little bit more about what it is. And it's making sure that it's not a top-down approach. Usually it's sort of we, as a clinician, give information to the patient, but here it's very much a reciprocal. It's really understanding, giving her information, but also receiving information from her. It's that two-way street of education, understanding our responsibility, her responsibilities. What are her values when we're making those treatment decisions? What are her preferences, and how can we best have mutual respect for each other? And it's also being okay if she makes a decision that we don't necessarily agree with. How do we work through that as providers? This is a shared decision-making tool for treatment of opioid use disorder during pregnancy that Connie Guile created, and happy to share that tool if you'd like more information about it. The other thing I think that we don't talk enough about as a field is how to measure recovery. We spend so much time talking about substance use disorder severity that we don't spend enough time talking on the other end of that, which is how to measure recovery. And I really like this tool. It's just a really short tool about how to measure 4 domains of recovery that I thought might be helpful for some of you all out there working with parents. So to summarize, family is very much needs to be defined by those being served. Trauma-informed care is so much of an essence of a family-centered treatment model, about empathy, it's about respect, it's about empowerment, and there's so many ways to get this done. So I hope I've given you a flavor of what it is like, and I am happy to answer questions. Thank you so much.
Thanks, Hendrée. Wow, lots of information. Let's go to some of the questions that have come in while you've been speaking to us, and I'm gonna combine a couple and then we'll keep some separate for obvious reasons. Some of them linked together, so that's that will be helpful. So the one question was around how a trauma-informed structure, when you talked about trauma-informed organization, how that might look in a virtual setting, or maybe some of the adaptations in your outpatient program. My guess is there probably been some restrictions around in-person therapies, right? So can you talk, any adaptations in this environment around trauma and some of the, you had talked about, a welcoming organization and some of those environmental cues, if you will, that can either trigger a trauma response or mitigate it and provide support. Can you talk a little bit about that?
Sure, I'd be happy to. Yes, I didn't mention anything about our COVID-19 response. So we've done it in a number of different ways. I'll just highlight a couple of them. So one really simple one that's super basic is all of our therapy and case managers that are virtual, that need to be virtual, especially for our outpatient care, and making sure that their backgrounds are very intentional, so that they are just as clean and therapeutic and harmonizing, thinking about the lighting that we're using when we're doing either the group or the individual interventions with folks. Talking to women at the very beginning when the whole COVID pandemic hit, making sure that women understood access, what that was going to be like, talking with them about their data plans, talking with them about their minutes, how can we best be responsive for them to make sure that we're using their resources as little as possible, talking with them about where, if you are stuck in your house and there is an interpersonal violence relationship that you can't get away from, how to keep yourself safe, how can you participate in our therapeutic opportunities that we have to provide in the safest way possible. Can you go, into the bathroom, lock the door? Can you, go to another sort of space? Some of our women were still going to work, and they would actually use that work that break opportunity in the safe break room to have conversations with us, making sure that we had a safety plan and a crisis plan in place if we saw something, because in the background, you could have anybody walking through because we only know what's on the screen. So having a clinical crisis response protocol that was for virtual. So we knew who to call if we needed to get in touch with somebody, a close associate or somebody maybe to help her, or, being able to call another safety entity for her. So that's just a couple of the different ways that we've responded to that.
Great, thanks. So this is kind of a two-part question. You had a slide around care coordination, around maternal and infant health care, child welfare, SUD treatment, and some of the other array of services, right? That's a challenge. So the first part of the question is kind of what have you found to kind of be the glue to hold that together? Case management, how does that happen? Who helps do that? There's a lot of care coordination in the context of plans of safe care. If certain communities are doing prenatal plans of safe care, and then how does that information, get from there to a hospital, to postpartum care? How does it inform child welfare? And kind of the sub part of the question, or the second part of that question, is within the context of confidentiality. There's a question around a release of information that's universally accepted. We know that SUD treatment releases of information are very specific, and have very specific requirements in order to allow you as a treatment agency to share information. So can we kind of bring those two pieces together and talk a little bit about that?
Sure, yeah, absolutely. So we are incredibly fortunate with the block grant funds that we receive to be able to support case management. It is not a billable service in North Carolina. And so when we bring a woman into treatment, either outpatient or residential, she gets assigned to like a team, or a team gets assigned to her. So there's a therapist, and there is a case manager, and there is a maternal child therapist. So it's kind of those three people that work together to coordinate that care. A lot of it ends up falling on the case manager, who is helping to connect the dots. I call her the connective tissue of making all of the treatment happen. We have a whole set of templates of those releases of information that have been vetted through UNC Healthcare, so that we know, and that the woman is a part of, like, what information are we allowed to share about her, and in what ways. We have to keep a whole log of obviously where that information has been released. We have to prevent re-release of information. So it's a lot of digital paperwork, if you will, to make that happen. And so much of it, if it wasn't for our block grants, it wouldn't be paid for. So I recognize that what I'm saying is something that is not attainable for everyone. I'm a firm believer that that case management piece, and what I've seen actually work, is one person being responsible and working very closely to connect all of the dots in collaboration with that woman. So because if we're working harder than she is, there's something backwards about that. So the case manager will often sit with her. I mean, even like in a virtual setting, where a woman needs to find a primary care provider, right? And needs to find a pediatrician. So virtually, we've been having the case manager sit with her. We go through the list. Hey, what looks good to you? And help her get that process. And now with, the electronic medical record, in some ways it makes it easier because she can get that communication faster. But yeah, it is, there is no easy, I haven't yet to find a really easy way to do that, but designating one person as sort of the lead conduit and advocate and navigator of her care and her child's care has been very effective for us.
We find that as well when there's community organizations doing prenatal plans of safe care. If that person can then stay with that woman, usually, obviously through the birth, if that family gets referred to child welfare to do similar function, and that continuity occurs much better than if there are handoffs, or if it's really not as articulated, as clear cut as that.
Yeah, and I think just to follow up on that, I think that is one of the things that is really beneficial about the Horizons model. It's not that we just treat pregnant patients, right? So we treat women that come in if they're pregnant or they're parenting. So maybe they're parenting and then they become pregnant. Maybe they're pregnant and then they're parenting, but we still follow the woman and her child through her whole course of the lens we look through is substance use disorder treatment, but that can be 2 years or 3 years or whatever, or it could be 9 months. It just depends. So we're able to, our treatment is based on her response to care and not by time, if that makes sense.
Yeah. Would you be willing to share us, or we could share with folks that the template for your ROI, for your release?
Oh, yeah, sure.
Just send it to us and we'll get it out to the participants. There was a question from Sue in Arizona. So
Yep,
I think,
yeah,
thank you for that. Thanks. Toolbox. So the question talk a little more about what's included in the self-care toolbox.
Yeah, absolutely. It's something that I created when I came to Horizons, and it has different, so one of the things it has is 50 ways to take a break. It has a whole section about how to build your social lifeboat, because one of the ways that I conceptualize recovery is around connection. It's connection with self, it's connection with higher power for some people, and it's connection with others. And I think about that in terms of how to live a life in recovery. There are elements of that that's important for those that have never had firsthand experience being in active addiction. And so connection is such an essential human element. And a lot of times when we get burned out, we start withdrawing and isolating, and that can make the burnout worse. So there's a whole part about social lifeboat. There's another part that's very introspective. It's to ask yourself in sort of 4 quadrants of mind, body, spirit, and leisure activities. Like, what are you doing well? What do you need to work on? And where are those things, other things that you need to work on? What do you, where do you want to start? And then it kind of walks you through from understanding what your coping mechanisms are, that maybe some of those coping mechanisms are really serving as stressors, and then what we can do about those, and setting goals for yourself about how do you envision your life to be. And that toolbox, I walk around the office, sometimes I'm in the office today, and I kind of look, and it's interesting to see sort of what people have posted. Some people have, they'll show me, they're like, look at this, and they've stuck their emergency self-care plan in their desk. And so they'll come up with a little box of what are those emergency things. It might be like a really special tea bag, and maybe some little lip care. It might be hand lotion. It might be 10 things I need to do to feel good, like take a walk outside. So they can pull that list out when they get really stressed.
Good, thanks. The woman that you shared the case study on in your presentation, right? So there's a question around how you worked with child welfare to ensure safety for the mom and kids, right? And the agreements that may have been worked out. It's a question, that's a specific question, but it's a question that comes up a lot that we see around, and it's probably a question that's coming up around family first, right? Around placing children who are in foster care in that situation in family first, but with moms, and then ensuring the safety and the kind of relationship and information sharing to ensure the safety. What questions have come up with us over the years, or what if mom just takes off with the child, and so so the questions around child safety, and I think the kind of agreements and understandings, and I think a part of it is trust, in trust in what the program does to ensure safety when an infant or a young child, or any children for that matter, are placed with a parent in a residential program.
Yeah, so there's a bunch of different ways I can answer that. So one of the things is with our residential program, like many residential programs, we have to have 2 staff members that are on site at all times. We do not have cameras in the apartment, so each mom and child, and there can be up to 3 children depending on the ages and sexes of who's coming, go into their apartment. We do rounds, so we have keys, and so we will knock. We consider that one of our trauma-informed practices. We'll knock, but we come in and we check everywhere. We do rounds at random, but frequently. so we can make sure. We also have the therapist going in. We have the case manager that goes in. We have our, residential support staff that are going in, and we have our maternal child therapists that go in. And even during COVID time, I often say that probably our women, like the only people that they see, they're probably some of the safest women and children that we have. We've not had a COVID positive test of any of our patients, women or children, at all. And that's because we do a lot of monitoring and we help support them to do the right things to keep themselves and their children safe. So there's a lot of monitoring. There's also a lot of discussion, and there's a lot of trust building. So we have eyes on the child, we have eyes on mom. We're learning from her, and we're also helping to be really responsive to her needs, so that so that treatment, when it's really hard, doesn't have to be punitive, that it can be something where she sees the value. And I'll also say that the women that come to us, they are really working hard to be the best parents that they can be. And so there's definitely, maybe we're only getting a small segment of the population, but it's kind of hard to get into Horizons. So there's a lot of motivation that's already built in there. And I think that also helps. And then a lot of communication. So we'll have like guardian ad litem that might come, or child protective service might come to see. And because we've been around for so many years, 27 years, we do have good working relationships with a lot of the DSS's, Child Protective Services workers and folks in town. So there's a good, easy ways of communication and good trust.
So not only are you a clinician and you're a program director, but I also know you're a researcher. So there's a question around outcomes and what you look at for measuring program outcomes.
Yeah, absolutely. So one of the first things when I got to Horizons, I was like, show me your outcomes. And I couldn't. So I was like, okay, that tells me where we're going to start. So outcomes that we're really proud of. So one of the things, and we have not done this as systematically as I'd like to. And so we actually have we got funding for a systematic 2-year follow-up of all the women and children that came in a fiscal year. And we're following them for 2 years post-treatment. So I'm really excited to be able to take a look at that data and see how we're doing. So the outcomes I'm going to tell you are from a programmatic standpoint, which is, filling out the comprehensive clinical assessment, and then looking at our clinical database and outcomes in that way. So we get about 57 women that come into residential treatment every year. And of those women that complete that treatment, over 95% of them have positive child protective service outcomes, which I think is really amazing. It means that, their cases are closed, and that we're having really positive outcomes for moms and for children. The other outcome we're really proud of is 77% of our women, when they leave our program, leave with a job. And then, so those are the two things in our birth outcomes. Are the other thing that we systematically track. We have about 51 babies born every year in our program, and less than 5% of them have low birth weight and or born early, which is better than the North Carolina state average. So those are some of the things, but stay tuned. In 2 years, I can share my systematic outcomes with you.
Yeah, cool. Great. Thanks. I'm trying to see if there's other questions. Cost individuals and programs. You mentioned Block Grant, this is a very rich program, but every state has a Block Grant, has a substance abuse prevention and treatment Block Grant coming from the Center for Substance Abuse Treatment. But the question was around costs to individuals and programs. Can you talk a little bit about that? Yeah, please.
Absolutely. Yep. And so actually with our systematic evaluation that we're doing, we are systematically also looking at cost and cost benefit analyses. A back of the envelope calculation has estimated that we can actually save the state of North Carolina over $3 million a year. When you think on average, it costs about $12,000 a year to treat every woman-child unit. And I mean, that is like half the cost of a year of foster care in this state. If you think about, an emergency department admission or a NICU stay that might average $10,000. I mean, just the sheer sort of return on investment, again, back of the envelope seems really important, but stay tuned. I'll have more data for you soon.
Yeah. Well, if you break down $12,000 a year to $1,000 a month to $30 a day,
Yeah.
to $30 a day, right? I mean, if you look at it, you break it down, that's, it's not a lot. And
Absolutely not. Not when you consider
the cost of healthcare, and
incarceration, NICU care, right?
foster care.
Yeah, exactly. All of that.
We're getting wrapped. I'm going to ask you another question. This is a Ken question. We've talked about this in the past around residential is it's the Cadillac. You know, what you're doing is the Cadillac. And so it's not easy, but easier to wrap around the services in a residential setting, right? Not easy, but easier. Easier than what? Well, easier than making those links and access to those community supports and engaging families in those other family-centered supports, right? In an outpatient setting. So I was going to kind of ask you about, you know, your ideas, what strategies that you're finding effective in helping families make those linkages. So it's not just having the agreements that says, oh, well, you know, we can refer here, here, and here, but the engagement on an outpatient basis for persons struggling with early recovery, struggling with the disorder, at the same time, trying to get them access to the services and supports that are more family-centered, but also those basic needs that often are related to sustaining early recovery.
Yeah, right. And so patience patience and perseverance are two characteristics that are really helpful for doing this work. Also, too, I think knowing it's not just enough to give a woman a referral or a family member, a caregiver, a referral. Needing to connect the dots for them. Even being able, we've even done such things, you know, like if there's a phone and they're here and we call together. So like if, for example, if we're trying to get a dad into treatment because he's in active addiction and mom is, you know, really been doing well, but struggling with her substance use disorder. And we know that if we can get him into treatment, that this could really help benefit the family. So picking up the phone and calling Healing Transitions together and saying, hey, Chris, you know, I want to introduce you to somebody and would you mind having a conversation with him? And making that, like, I call it a hot handoff. So it's more than just a warm handoff. It's truly being there together. The other thing that we do too, in terms of, so we have our prenatal, perinatal care clinic. So for one kind of dose of Horizons, there are pregnant women that come in to see us. They initiate their treatment with us in terms of being pregnant and receiving the prenatal care from us, as well as psychiatry, case management, and individual therapy, but we do it all linked to their prenatal care appointment, postpartum appointments. And that can be, so a lot of times we'll have a family member come in the waiting room, right? And maybe their other child is with them. And so this gives us an opportunity to interact with that other family member and with the child, have that sort of informal conversation, if appropriate, meet together with the woman, the family member, and, you know, maybe the little child's running around, or we have a little child place area that the receptionist will stop what she's doing, go and watch the child while that conversation happens. So it's building trust, it's building rapport, and it's knowing your resources like the back of your hand. The other thing we do is we keep this pretty comprehensive list of all of our resources that we update every 6 months in a paper form as well as the electronic form, so that we can, like, what do you need? You need dental care. We know this dentist who's really kind and compassionate towards those that have substance use disorders, and he takes Medicaid, right? So because there's nothing worse than sending somebody somewhere and they have the wrong insurance or they don't take that insurance or they have a really bad experience. So.
Great, thanks. Well, we're good. So I don't know how to do that on the screen, but so on behalf of everybody, thanks. Thanks again. So reminder, folks, colleagues, friends, reminder that Dr. Jones and Dr. Turpin and Dr. Grossman are doing a concurrent session at the Policy Academy as a follow-up to these three plenaries, if you will, so that you have the opportunity to talk more informally or actually talk in person. Orally, you know, and if not in person, yeah, but you know what I mean, as well as just have more of a dialogue, a focused dialogue on what you heard from each of the three presenters. They are concurrent, so suggest that you guys get together with your team and so that you can cover all three depending on your areas of interest, areas of need, as well as the interest of your partners in your collaborative. And yes, this recording will be made available. And if any of you have joined this webinar and haven't been on the previous two, the previous two webinars are available and if you don't have them and need access to them, you can contact us, contact your change liaison, and we'll make sure you get access to them. We need you to register for, we're coming into the home stretch, right? We're a little less than a month out from the actual event. And so we need you to register, and you can see here the website, the link for registering for the practice for the actual event, the end of August, this 2.5 days. Submit a picture, right? So we've got to create a picture that represents your team. You also see in Excel events the opportunity to enter a picture, personal picture, right? Your picture. So take advantage of these. We're in a virtual environment, and we're looking for ways, and you probably have experienced a lot of ways to make them more personal. So enter a picture of yourself and enter a picture that reflects your team, and be creative in any way that you want. We want to, as much as possible, connect with each other and compensate for the lack of physically being able to do that. We just released, Janelle just sent out with the registration link. We just released, just for you all. What I mean by that is that we got approval from the Children's Bureau, which we appreciate, to give you, Policy Academy participants, brand new 5 modules, a 5-part series, 5 modules around plans of safe care that take you through both the planning and implementation of plans of safe care and monitoring. So the modules are designed with 2 things in mind. You can build on the modules developmentally, or those modules are designed to be freestanding, depending on what your needs are in looking at implementing plans of safe care in your respective states. I mean, some of you are looking at alternatives to traditional CPS reports or referrals through notifications. With that, looking at who else might do a plan of safe care besides child welfare as an alternative to a child maltreatment report, and an alternative to having an open child welfare case. So those kinds of things are covered, and examples of what other states are doing are included in the modules. Janelle, am I missing anything? I'll put you on the spot.
No, I think you covered it well. There was one other thing. The CLs have been in touch with the project liaisons about finalizing the external profiles. So this is just a reminder to you all to get those wrapped up. That is another thing that we're trying to do to help connections across teams, to give each team kind of an overview of what the teams are working on. So that will be very beneficial for this virtual platform.
Great. I knew it was something I forgot, but I didn't forget to call on you, so that was good. So thank you for your time today, everybody. Andre, thanks again for a wonderful presentation. We look forward to connecting with you at the end of August at the Academy event. Thank you all for your time. These are challenging times, and I think of Lester Holt reminds me, right, when I watch the evening news, NBC says, take care of yourself and take care of each other, which is always a nice message and a valid message in this context. So, be well, be safe. We look forward to connecting with you the end of the month. And is there anything we can do in the interim through your change liaison or through us directly, please reach out to us. So we want to support your work leading up to the Policy Academy, and want to continue to support you after that. So thanks to our team in Children and Family Futures. I want to say in California, well, not all in California, but for the logistics and bringing together all 3 of these webinars, an alternative delivery, if you will, than what would have been planned had we been in person. But gone very well, and the participation has been great. We hope that it's helping you all out there with, as you develop your approaches, your strategies, the types of maybe modifications to current practice around serving families with substance disorders in child welfare, addressing infants with prenatal substance exposure and the needs of those families and caregivers, as well as the needs of those infants. Hopefully this can help inform your work leading up to the event, as well as your work in the time after that event. So we appreciate it. Be well, and we'll talk soon.
Bye, thank you.
Thanks. Yeah.